There we go. Okay, good afternoon, everyone. Thank you for joining our webinar this afternoon. I'm very excited to have Linda Farrar here today. Linda is a nurse and an administrator, and probably more importantly, she's probably one of the most passionate people I know about providing quality care for our elders, and specifically our elders with dementia and Alzheimer's and on all other forms of dementia. So I'm really excited to have her here. Before I turn the presentation over to her, I'm going to do just a little bit of housekeeping stuff and show you what you should be able to see on your screen, and that's something that looks like this. You should see a red arrow where you can expand or collapse that control panel, a place where you can make sure that you have your mic and your speakers are working and that you're accessing both of those things. And then most importantly, a place where you can show you where you can raise your hands if you have questions, or type those questions into the box. And we'll take those questions, I think, at the end. Is that right? Or do you want to take questions as you go?
We'll have Barb watch for the chat area, and she can certainly interrupt anytime during the presentation with questions. She'll watch for hands raised also.
Okay, well then that's what we'll do. So I'll pass this off screen over to Linda, get her presentation up here. If you just be a little patient with me, we'll get it going. And there you go. Just click, you'll get.
Okay, let's talk a little bit about dementia. What we know is that dementia is not a diagnosis in its own. There are probably 200 or more different kinds of dementia. The most common one that we know about is Alzheimer's type dementia, but really dementia is sort of an umbrella term that talks about what symptoms that the elder or the person may have that has affected their cognitive ability. The Mayo Clinic says that we must have 2 of the symptoms be affected before it's truly a dementia. Obviously, many of our elders have memory, either short or long term. When we're talking about memory, what we know about memory associated with dementia is that for all of us right now today, our short-term memory is our weakest and our long-term memory is our strongest. So memory must be affected to be considered as a symptom of dementia. Language may be also affected, and this can either be receptive language, so what we hear, we understand, or expressive language, which is what we say, the wrong word may come out. They may search for a word and the wrong word comes out. That is a symptom of dementia. Reasoning may be affected. You know how we all think we have common sense? Well, I don't think everybody does, but many people, we have this common sense ability to reason. And people with dementia may have a negative aspect of that reasoning because their judgment, their decision-making sequencing is off. So it affects their ability to reason. And then planning may be affected. Elders with dementia don't have the ability to plan in detail over a long period of time, even over a short period of time. And then also recognizing or identifying people or objects may be affected. So we have to have at least 2 of those symptoms. But the one we see most often with dementia that we are the most concerned about is memory. Although what we should be the most concerned about is that reasoning and safety judgment and that kind of thing. So eventually this decline can affect a person's ability to carry out everyday activities. We all have some cognitive disability at times, especially under stress or illness. We have disabilities in our cognition. But when it starts to affect our everyday activities, such as driving or hobbies that we may have done all of our lives, such as gardening and things like that, or even when it affects personal care, such as bathing or dressing or eating, that's when we know that we have a significant disability based on dementia. An elder may resist care, or they may become physically or verbally aggressive, or they may experience anxiety. One of the things that when I teach facility staff about resisting care, or they become they become combative because they are resisting cares, when I teach, I tell them, please don't use that word. Please don't use resists or non-compliant. Those are words that develop a prejudice in our minds, because then we believe that we have the right answers. But an elder that has dementia has every reason that makes sense to them of why they do not want to do what you want them to do, or what the staff or the caregiver is asking them to do. So I would much rather see the verbiage that they choose not to, because that's a right to continue to have choices, rather than resisting something that I have chosen that it would be best for them, or they don't comply with the things that I want them to do. That imposes my desires upon another person, and I don't really have a right to do that. Then let's talk about anxiety, symptoms of anxiety in dementia elders. Many of us have seen elders that become very worried, they're pacing, or they may be crying, or they may just not be able to track, and we identify that as being anxious. I will just tell you that anxiety is not a diagnosis. Anxiety is, and it can encompass many, many behaviors. So when a staff or a physician writes an order for anxiety, that must be very much defined for that person. And I will just tell you that I display anxiety. I have anxiety sometimes. And I display that anxiety much different than most of you would. You also are very unique. We have that uniqueness about us. That doesn't change. One of the things that we know is that every behavior is communication of an unmet need. And I'm probably going to say this again later on, but we have to figure out what the unmet need is. We can no longer continue to treat our dementia elders as if ours is the only way. We have to figure out the causal factors for this elder's behaviors and their attitude and their fears and their anxieties. Otherwise, we will not be able to meet those needs. Otherwise, we're just treating the behavior. We are not treating the causal factor. So let's look at some just demographic numbers. Dementia mostly affects people over 65, but it can occur at any age because there are some situations that cause dementia-like behaviors that actually destroy brain cells. For example, a frontal lobe injury, a head injury, where they hit the frontal lobe of their brain or it becomes bruised, a concussion of some kind. We're hearing about a lot of that in professional sports, especially football now. Also, alcohol-related dementia can cause the dementia of any age. So it is the only cause of death in the top 10 in America that cannot be prevented, cured, or slowed. Isn't that amazing? It is the only cause of death in the top 10 in America that cannot be prevented, cured, or slowed. So those other top causes of death. For example, heart disease, cancer, lung disease, diabetes, all of those we have some treatment for. To date, there is no treatment for dementia or Alzheimer's or any of the other dementias that are prevalent in the United States that are causing death. There is no treatment. So we have to pay attention to this. Almost 2/3 of Americans with Alzheimer's disease are women. That can be age-related. Women tend to live longer than men, and almost 2/3 of those will have almost 2/3 of the Americans with Alzheimer's disease are women. 1 in 3 seniors will die with some level of dementia. 1 in 3. Alzheimer's disease is currently the 6th leading cause of death in the United States right now, today. By the year 2051, the cost of dementia could rise as high as $1.1 trillion. And in 2015, dementias will cost the nation $226 billion. That's money we don't really have. We should be focusing our attention on cure, on appropriate treatment, and giving the elders with dementia the best possible care we can. That's where we need to be. And many, many of those treatments don't cost anything. They cost the amount of money that it takes to train people. Okay, some conditions that are not dementia. And we must be very discerning. All of the medical field, including advocacy groups, must be very discerning about when an elder truly has dementia or when they're showing something else. For example, depression. Depression is very widespread in our elderly. It is many times untreated in our elderly, and it is many times inappropriately treated. Sometimes physicians just think that if we give them an antidepressant of some kind, that will cure everything. Again, I want to emphasize the fact that we have to go back and figure out the root cause. I will tell you that elderly people have a reason to be sad. The losses in their lives not only have accumulated over the years, but the losses that they experience at the end stage of their lives are significant. So we have to figure out a way to meet the needs of the elders with depression, because oftentimes it gets treated as a dementia, which is inappropriate. And sometimes it gets treated with an antipsychotic medication, which is absolutely inappropriate. Delirium. The definition of delirium is the fact that it is a decline in cognition that is short term, and it is a sudden onset. I will tell you, of all the diagnoses that are associated with dementia, none of them except one are sudden onset, and that is vascular dementia. Vascular dementia is usually caused when there is a sudden cardiovascular event. So it can be a heart attack that deprives the brain from blood. It can be a stroke that deprives a specific little area of the brain from blood. It can be a clot of some kind, a bleed, or a blockage of some kind that affects the brain, and that is sudden onset. Now, that also progresses in a very step-like manner. It isn't a true progressive neurogenic disease. Delirium, on the other hand, is going to be sudden onset, and it is reversible. The biggest cause for delirium in elderly is medications and medication drug interactions. I will tell you that Dr. Ryder, who is the president of the Kansas Medical Directors Association, believes and teaches that if an elder takes 5 or more drugs, and believe me, very few elders take 5. They more apt are going to take 15 or 25. If they take 5 or more drugs, there is a 100% chance of drug-to-drug interactions. Many times that is a delirium. Another cause for delirium is often an infection. In the elders that we see, most often that's going to be a urinary tract type of infection or an upper respiratory infection. None of us, when we are sick, we don't feel the same. We don't act the same. Our thinking isn't as good when we are ill. And yet that comes back around when either the stress or the illness has been resolved. There's nothing unusual about this, but we cannot get into the fact we need to treat someone if it is a short-term issue. Another condition that is not age-related is vitamin B12 deficiency. Lots of doctors now are paying attention to vitamin B12 deficiency. We've already talked about drug interactions. This can be either recreational or prescription meds. Many of the generation that is coming into senior living settings at this point have either had some experience in the past or currently have some experience with recreational drugs. We have multiple states in the nation now that have legalized both medical use and and recreational use of marijuana. Those drugs actually do change cognition. Then the other one that I skipped over because it is something that we tend to believe is pretty common is age-related cognitive decline. And I will tell you that true dementia is not a normal part of aging, but there are things that happen that might mimic cognitive decline or dementia that is truly age-related. Our reflexes slow. Our memories decline some, especially our short-term memories. It is not abnormal and it is not considered dementia if you lose your keys or you walk into a room after you've been doing something and you forgot why you walked in there. What we can do is go back and recover that. We will eventually, the right word will eventually come to our mind, or we will eventually be able to remember by backtracking and following our steps of why we went into the room or where we put our keys, things like that. That age-related cognitive decline is not true dementia. Okay, so here are some early signs of dementia that people need to pay attention to. Short-term memory problems. We've already talked about short-term memory is our weakest. So we need to put things into place to help our elders with that short-term memory deficit. Making lists, writing things down, using mnemonic devices. We need to focus on the tools of our long-term memory to help our short-term memory. For example, I will use an example that I do sometimes in facilities. If an elder is admitted to a facility and they're very much under stress, they're very tense. First of all, they didn't go there because they have moving into a nursing home on their bucket list. I promise you that that didn't happen. It's not on their bucket list. So they're under stress anyway, and the staff is going over all of the new things that they have to learn. They have to go over where's the bathroom, where's the closet, where's maybe meeting a new roommate that they've never met in their life, that they don't know from Adam, but they're going to spend intimate time with for a long period of time. Meal times, what to do with laundry, when can I see my kids, all of those things. And then the staff will hand them a call light. Well, short-term memory is your weakest. They've never had a call light where if you push this button, someone will come. They've never had that. I'd like to have that in my house, actually, but I don't have that in my house, and neither did they. So some facilities have started trying to use long-term memory to facilitate short-term memory. So one of the things that they have used is that when we think, right now today, all of us who are cognitively intact, when we think of the color orange, most of us will think of caution because we think about cones in the road, construction, I need to slow down, I need to be careful here. Some facilities are actually wrapping call lights for the first few days of an elder's stay in orange duct tape, because that is using their long-term memory in order to support their short-term memory. Any sort of device like that is absolutely necessary for people with dementia. Then difficulty choosing a suitable word. So I know what I want to say. It's right there on the back of my tongue, and yet they can't figure it out. And so a different word comes out, or maybe an inappropriate word comes out. Though that is a sign of early dementia. Mood swings is also a sign. When we have an Alzheimer's type dementia, which has affected every lobe of the brain, there are some kinds of dementias that don't affect every lobe, but Alzheimer's type dementia affects every lobe of the brain. The frontal lobe of the brain it's what acts as our brakes. We remember what our mom taught us about how to act and what to say. Well, when you have early stage dementia and we all have these mood swings now, we just control how we act on those mood swings. When you have frontal lobe affecting your dementia, then those mood swings are apt to come out and be more prominent. So what we know is the inhibitions have been taken away because of the disease. And so we need to step in and confirm where they are and say, it seems to me like you're really sad today, or it seems to me like you're really angry. Can we just talk about this? This is especially good in early stage or mid-stage dementia. The next sign might be difficulty making plans and problem solving. And I will tell you that as you age, it becomes more difficult to see all of the ramifications of a decision. So we need help with that. Your elders with dementia need help with how do you do the problem solving sequence. There is a sequence in problem solving. The first step is you recognize that there's a problem. And elders with dementia are very, very good at knowing that there is a problem. The next step is to devise a plan, a solution. Well, they aren't quite as good with that because they don't see what the follow-up might be. The next step in decision making, and we all do this, is to actually implement that plan. Now, I will tell you, after I've worked in long-term care for more than 30 years, I didn't always like the plans that they came up with to solve problems. It causes people to fall because they cannot think through. I've got this uncomfortable sense in my lower gut, and something is wrong. It's really uncomfortable, and something is wrong, and I can't figure out that I need to go to the bathroom. But I know that I need to do something, and so I get up. Well, what would have happened if they would have anticipated that need, if my caregiver would have anticipated that need so that I didn't get into that sense of discomfort and I wouldn't have gotten up and wouldn't have fallen? It's that kind of problem solving. Now, I will tell you the last steps of problem solving is, one of them is you go back and you evaluate the success of your intervention, and your elders with dementia are not able to do that at all. Then another sign of dementia is difficulty completing everyday chores. They may very well get started, but they have great difficulty completing. They have great difficulty thinking through the sequencing of what they need to do. Difficulty understanding time is another sign of dementia. They just get days and nights mixed up. If you tell them, I will be with you in a minute, and you don't come back in a minute, and you come back maybe 15 or 20 minutes later, it seems like hours. Or we have people especially early signs of dementia, that say, my child hasn't visited since I've lived here. Well, that has to do with short-term memory, and it has to do with how long time seems. Some of that is the actual dementia, the brain cell involvement in not being able to understand the concept of time. Some of it also has to do with a lack of meaningful activities and things like that, and it's just plain boredom and loneliness. Difficulty recognizing places or people. If you have never been really good with recognizing faces and putting faces to names, you will not get any better when you get dementia. I'm sorry to tell you that, but it doesn't suddenly get better. If you were really good at it when your brain was functioning appropriately, you probably will start having some difficulty recognizing places or specific people. Now, in end-stage dementia, you may very well not even recognize those people that are very, very important in your life. You may not recognize your spouse, or you may not recognize your children. You will, however, in almost every kind of dementia, every specific kind of dementia, you will recognize that it is someone that is important. It has been important to you, but you may think it's your father when it really is your son, or you may think it's your husband when it really is your son. Those kind of things. Problems reading or writing. One of the problems that I see with dementia is that we don't give elders the opportunity to read or write. I can't tell you how many times when we gave an elder a piece of paper and a pencil, they could actually still write, but it wasn't as good as they used to be. I noticed today, before I came over, I had to stop at a business and sign my name. I hardly ever sign my name anymore. We don't use checks anymore. You use the check card and all of those things. And when you lose it, you lose. When you don't use it, you lose it. I didn't even recognize my signature. I don't know if it'll go through or not. We become repetitive. It's because our short-term memory is affected. And so we become repetitive. We may say, we've all heard the same stories over and over and over. And at first, they will tell you, I may have already told you this, or have I already told you this, or that kind of thing. Eventually, they won't have any memory at all of being repetitive and already told you. Lethargy is an early sign of dementia. This is very interesting. This can be due to a number of things. One of these things may be depression. If we become more lethargic, if we just want to kind of lay around, or your elder with early stage dementia just doesn't have the energy level that they had. Now, I'll tell you, with age, you lose some of the energy level. You need more rest, frequent rest periods, and so do your folks with dementia. Many of the behaviors comes from sleep deprivation. They don't sleep well at night. They nap frequently during the day, but not for long periods because there's environmental stimulation going on, and so they're sleep deprived. And I would ask all of you today, right now, how do you act when you're tired? You don't act the same way. You get grumpy. Some people get grumpy. Some people just can't get up when they get tired. That's what these folks are going through. We must start focusing on adequate sleep for our elders with dementia. And that may mean naps right when we're having bingo. Doggone it, I want to go to bingo, but the elder may really need to nap in the mid-afternoon. They may even need to nap mid-morning. So we need to start, as advocates for the elders, we must start asking and expecting that people are going to provide environmental and psychological stimulation at the needs of the elder, not at the schedule of other people. Elders with early stage dementia will avoid change. That's because if they've got it in their long-term memory, then they can be successful. But if you change something, then it will be more apt that they will not be able to do that successfully. One good example is brushing your teeth. We all have a procedure that we follow when we brush our teeth. Some people put the water on the brush and then put the toothpaste on. Some people put the toothpaste on and then put the water on. They will be successful in doing those simple procedural tasks if you don't ask them to change. But if you ask them to change, you will stop the process and they will not be able to complete it. Think about yourself and how hard it is to change a process in your life. Then they have difficulty following a storyline. I will tell you that one of the things that we need to remember is someone in mid to end stage dementia's attention span at the very most is 15 to 20 minutes. At the very most. It is all they can do because their brains will not allow them to focus attention longer than that. I can't tell you how often I go into facilities and I see a movie playing in a dementia neighborhood or a memory care unit. They cannot do it. Those elders cannot follow that storyline. Now, lots of things available out there that will last 15 to 20 minutes. A lot of things are out there, but that's all they can do. That's all they can follow. I went the wrong way. Okay, so how do we support a person with dementia? We need to change the mood. Obviously, non-drug methods are preferred. One of the things that Barb didn't tell you about me is that I facilitate the Kansas Partnership to Improve Dementia Care. It is an arm of CMS, Centers for Medicare and Medicaid Services, program to improve dementia care. Kansas is trying really, really hard and not making much progress, folks. Kansas is currently ranked 47th worst in the nation for the use of antipsychotic drugs for dementia. 47th worst. Now, we have made some progress. We have had a decline in medications of 19.9%. But all the other states are making progress too, and we are still 47th worst. We're working hard. I will tell you, remember when I told you that every behavior is communication of an unmet need. The number one trigger for dementia-related behaviors is pain. The number one trigger. So rather than give someone an antipsychotic medication or an anti-anxiety medication, maybe we should have just given them a couple of Tylenol. Wouldn't that be sad? Wouldn't it just be sad if that's what it was and we didn't recognize that the person was in pain? Because they can't tell us. They can't put together the process to know that this is pain. They just act on their instinct. Depression. We need to pay attention to depression in our elders. Again, I go back to how many losses they have had. They have given up everything, and finally their brain failed them, and now they can't think anymore. We need to change our approach. I wish that everybody on this webinar right now, right this minute, from this moment forward, would never consider what elders with dementia can no longer do, but rather focus on their abilities. They all have abilities. Even folks in end-stage dementia have abilities. So if we would just change that mindset, that we don't care what they can't do anymore. Why do we care what they can't do? There's a lot of things I can't do. I can't run a marathon. I never could. I never wanted to. Well, that doesn't define me. We have to stop letting dementia define the elders that we serve. And we have to focus on their abilities and their strengths rather than what they can no longer do. It's not their fault. They have a simple disease. It's not very simple sometimes, but they have a disease that is changing their lives. But there's still things they can do. Even end-stage dementia folks can still smile and they can still experience pleasure. And that needs to be our focus, on changing our approach to get them to do what they can do. For most people, entering their current reality will minimize stress and disorientation. As I said, I've been in long-term care and senior services for 30 years. When I first got in, reality orientation was a big positive thing. We would try and get them to understand the day. We would try to get them to understand the season. In fact, we put up big boards, huge boards on the walls that says, the season is fall. Really? Who cares? They don't care. I guarantee you they don't care. Rather, let's go to where they are. Let's go into their life. There is a wonderful lady that has been to Kansas a number of times. Her name is Naomi Feil, who actually developed the system called validation therapy. And that means that we go into the world where they are right this minute. It doesn't matter if that's not real to us. I guarantee you, I am sitting here in Barb's office across the street from the Capitol. And I will tell you that my perception is not always the same reality that they have, or vice versa. We need to go to their perception is their reality, and we need to step into their reality. Because here's what I know will not work. It will not work for you to try to argue them into your reality. First of all, there's no guarantee your reality is right. Second of all, it won't work for them. They can't do it. So just enter their reality and be there with them. It's the most important gift you can give them, is to be there. Your presence in their reality is the most important gift you can give them. So contradicting the person, how does that feel? When somebody tells you that something that you believe is true is not true, how does that make you feel? Do you get kind of angry sometimes? Do you get anxious about that? Do you need to talk them into changing their mind? Maybe it's going to lead to an argument. Is it worth it? Is it worth it to argue with a dementia elder about your perception of reality? As I say, there's nothing to say your perception of reality is right, and I guarantee it isn't right for them. Just go to where they are. For example, if somebody's saying, I want to go home, trying to convince that person that they're in their home, this is your home, that doesn't work. They know this isn't their home. Now, they may be living there now, but it is not the place they called home for their adult life when their brains were functioning appropriately. And it will cause distress. Tell me how you would feel if somebody said to you right now, in the place where you are, this is not your home. This isn't it. You don't live there. Would you get anxious? Would you want to argue? Would you want to almost fight to get out? Because I'm telling you, almost every facility now, including assisted living facilities, have locks on the doors. I want to know how that would feel to you. You are in a place you don't recognize as being where you should be. You're around people you don't know. Sometimes we believe we've never met them before. And the door is locked and you can't get out. Tell me what your reaction would be. Would you become quote unquote combative? Would you be quote unquote exit seeking? Absolutely you would. Would that be an abnormal behavior? No, it would not be abnormal, because their perception of their reality is, this is not my home. I need to go home. If I go home, I'll feel safe. but I don't feel safe now. Think about what they're going through, folks, and just move into their world. Go into their world. Don't tell them this is your home. It's not. Don't tell them that. Rather, you could say something like, isn't this a beautiful place? Let's go into this room right here. I think I saw some things that you might like. And then show them something that they brought with them that makes them feel comfortable and safe and loved. Offer them a cup of coffee. Treat them like people. Treat them like human beings, not like dementia people. So the elder's perception is always the elder's reality, always. I can't emphasize this enough. You will not argue them out of their perception. It won't work, and it will only make the situation worse. Then think about what that underlying emotion is behind what they're saying, and then give reassurance based on that. Maybe if they're telling you, I want to go home, and you're thinking, well, this is their home. There's no place to go. Your kids have sold your house. You don't have very many of your personal possessions left. Ask them what it felt like when they lived at home with their parents and their brothers and sisters. What did it feel like then? You need to get to the emotional basis rather than that cognitive basis. Get to the emotional basis. One of the best ways, and I will tell you that there's so much research out there right now, aromas are now one of the biggest devices used to emit memory. And they may not remember a specific event when you present an aroma that is positive to them, but they will get to the emotion of what it felt like when they smelled that aroma. One example that's coming up right away, when you walk in the house when your wife or somebody is cooking the turkey for Thanksgiving, isn't that just a wonderful smell? The reason that smells so good is because there's an emotion attached to that smell. So if we can get down to that emotional basis, and I will tell you, even people with end-stage dementia still have emotions. The love, the anger, all of those emotions, the loyalty, those emotional ties do not go away with dementia. They are still who they are inside. We just have to reach in there and find them. If someone is asking for their mother, maybe they're feeling anxious. Maybe they need to be comforted. So what they need is somebody to say, I'm here for you because mom was always there for you. Is there anything I can do for you? Maybe you offer them a cup of tea. One of the other devices that we frequently lose track of are foods that are attached with that emotional string that we have to that feeling of safety. And I will tell you a personal story. I was an only child. My mom died when I was 19. She was 46. She had metastatic breast cancer. It was a very ugly death. But as my mom and I were best friends when I was growing up. And when I had a bad day, came home from school and had a bad day, we never talked about it. We never talked about what was bad about it. Oh, once in a while we did, but not right away. But for dinner that night, there was a little bowl of warm, homemade tapioca pudding with a little bit of whipped cream on top. Now, I will tell you, tapioca pudding is not my favorite food. Those little balls in there are bothersome to me. But when I eat tapioca pudding, I feel safe because it reminds me the emotion. And sometimes I never even think about it, but the emotion is that of my mom and the tie that I had with her and that feeling of safety. And I needed her support for that. If we could just reach that point with an elder with dementia we can really fix the cause of the behaviors rather than just treat the symptoms. So then the next step might be to go on and talk about that person. I would love, even when I have dementia, I am convinced I will recognize tapioca pudding. In fact, today, my husband has heard me speak enough. Once in a while, he will ask me, Linda, is this a tapioca pudding day? And he will go to the store and buy me just one of those little plastic containers. He doesn't like tapioca pudding, but he'll buy me one of those little plastic containers of tapioca pudding, and that's all it takes for me to feel safe, because I know that he cares about me. So what it is we're acknowledging what the person is saying, not just dismissing it and not changing the subject. No, this isn't where you live. Okay, values in dementia care, we need to be elder-centered, elder-directed. Elders need to be given choices. They need to be given the assistance they need to live their lives with as much control and purpose as possible. I want you to think about people that are in your buildings where you go every week or however often you go there. And I want you to see what their purpose is so that you can tell them why you need them. I think it should be your goal every time you go into a building to tell those elders with dementia why you need them and mean it. They have a purpose, because what happens when no one needs us anymore? When we have no purpose anymore, what happens to us? Pretty much we just fold up and die. We may not be physically dead, but emotionally we die. We must be giving these people, even our end-stage dementia elders, we must be giving them a sense of purpose. The goals for dementia care should be that the elder feels safe. That is, if you've studied any human development, Maslow developed a pyramid of needs. The very bottom rung on the pyramid is oxygen, food, water, those kinds of things. The very next one up is safety and security. If you do not feel safe, you cannot advance up the pyramid at all. You will be stuck in that fear. They have many things to be afraid of. They have some things that they don't need to be afraid of, but they are afraid of. And we have to meet those needs in order to get them to have the ability to feel pleasure. They need to feel comfortable. We have come a long way in pain management with not a lot of side effects. Every drug has some side effects, I'll just warn you. But there's so many ways to help pain that don't involve drugs. They have a goal of experiencing a sense of control. I don't know many of you, Barb knows me kind of, but I can tell you when I'm not feeling in control, I'm out of balance. Many of us are like that. They're no different than that. They need to have that sense of control. They need to experience minimal stress with adequate positive stimulation. That adequate positive stimulation is a very individualized issue. We must be focusing on individualized positive stimulation to these elders' brains. And then they have the goal to experience pleasure. None of these things are any different than you and I. None of these things. They're the same people. They have the same hearts. They have the same emotions inside of them. We just have to reach in there and find them. Behavior is communication. Remember, I told you, every behavior is communication of an unmet need. It may be fear. It may be frustration. It may be pain. It may be any of the other unmet needs. I mean, it could be anything. It could be they're hungry. It could be they're thirsty. It could be they're cold. It could be they're hot. It could be their underwear is twisted. We have to figure out what those unmet needs are. It could be a loss of sense of self. They don't know who they are anymore, and we need to get to them, to their hearts, to figure out what that is. And then maybe it's an inappropriate expectation from a caregiver. I just told you that I have to go give this bath to someone else and I will be back in 15 minutes. Remember, their short-term memory is their weakest, their long-term memory is their strongest. If we expect them to remember things beyond what their abilities are, it's very frustrating. So we have to rely on other forms of communication. Facial expressions, we need to be watching them, because even in end-stage dementia, they will talk to you through expressions, through the little bit of gestures that they may be able to make, through their body language, any sort of negative behavior, you'd better be on the alert for. Your attitude and your body language communicate your feelings and thoughts stronger than any words. So, before speaking to someone with dementia, first of all, make sure you have their attention. Don't ask them to do something they can't do. You should minimize the distractions around them, because they can't pay attention to more than one thing. Their attention will automatically go to what gets has the biggest attention grabbing. So we have to minimize those distractions. Probably not a good idea to have a discussion, a real discussion with somebody in the dining room, because there's way too much going on in that dining room. I will tell you that if you are dealing with someone with mid to end stage dementia, their cognitive visual field, not what they can see, but what they can pay attention to, is 14 inches. It's important that you know that, because if you are talking to someone in an environment that has pretty high stimulation, the TV's going, or there's other people in the room, or there's some activity going on, and you are not within 14 inches, you become part of the environment. And then they have to decide what they're going to pay attention to. But if you're within 14 inches of them, they will see, you will be the thing that they are paying attention to. That's what their cognitive visual field is 14 inches. Anything beyond that is all environmental. Make sure you're calling them by the name they prefer. You need to know that. Ask the staff. Ask them, what do you like to be called? They will tell you. We had a dementia elder that wanted to be addressed by Mrs. and her last name by men, and she wanted to be called by her first name by women. That's great. Whatever, she saw it as a sign of respect. She was pretty far advanced in her dementia, but she knew that about her, and she would tell you that. Then make sure you're using nonverbal cues and very gentle therapeutic touch. Now, I'm not talking about approaching them from the back and starting to rub their shoulders. That can be fearful. Somebody comes up from behind you and you don't know who it is or what they're doing, and they take a hold of your shoulders. Use very gentle therapeutic touch. That may be nothing more than just a gentle hand massage. Just stroking the back of their hand. If you actually hold their hand, there is an acupressure point in the webbing between the thumb and the index finger that is a tension relieving point. It would be great if you would just gently take their hand and rub between their thumb, and don't push hard. It hurts when you do that. There's also a point down in there that will relieve headaches, but that's pretty deep and you have to push hard. And if you have a headache and you actually use that acupressure point, you will feel tenderness in there. Don't push near that hard when you're just doing gentle hand massage. Just gently rub that little webbing area, and you will be able to reduce their anxiety. Then make sure you are on eye level. Maintain eye contact. If they are having some behaviors and you're able to, leave them alone and come back later. Their sequence of their thoughts are quick enough that they probably won't remember. So make sure they're safe. But if you are able to, just leave them and come back later. Then talk about what is of interest to them. Don't talk about what your interests are. You know, I would be glad to visit with you about your interests, but you need to focus on them and their routines. Make sure you're trying to gain their trust. Don't do anything without their agreement. Give them as much control as possible. Reduce the stressors. If you talk about a subject that you can see is causing agitation or a little bit of anxiety or tearfulness, stop talking about that and talk about something that's very safe for them. Also reduce the environmental stressors. There are some. Make sure that they are not having pain. If they are, please report it to someone. And then start helping them develop relationships. And they will do that through familiarity. They won't remember your name. I almost guarantee they won't remember your name from one week to the next. But they will recognize that you are someone safe and someone that cares about them. Minimize the time they're left alone. Listen and support them. Make sure that their needs are being met. All of those needs that we talked about that might trigger some behaviors, those needs need to be met. They can't have a meaningful interaction with you if they're in pain or if they need to go to the bathroom or those kind of things. Make sure that before you have an interaction with them, you're actually making sure that those needs have been met. Make sure that they are engaged in valued activities, and that is so individualized. One of the examples that I frequently use when I'm teaching is that I love Matlock. I watched Matlock this morning before I drove over to Topeka. Matlock reminds me of my dad. I just really like Matlock. I would do lots of things in order to watch Matlock. I would rearrange my schedule. I would do some things to do that. My husband can't stand Matlock. It is just a waste of time to him. My husband likes to watch bicycle racing. He bicycles for pleasure. He is actually going to retire next spring on May 1st, and then his gift to himself is he's going to ride that crazy bicycle across the state of Colorado. Now, I have a great vehicle. I love to go to Colorado. I have a great vehicle. I could drive across those mountain ranges, but no, he's going to ride his bicycle across them. So for him, turning the TV on, and if Matlock were on, you would completely lose him. But it must be individualized. It must be something of value to them. Then be sure that when you are asking them to respond to you, make sure you're asking questions that they can answer with yes or no and not long thought out sequential answers. Make sure that you're giving your message clearly. Use simple words and sentences. Speak very slowly. Use declarative sentences that will initiate an action. Provide clues in your statements to what you want them to do or say. Listen with your ears, your eyes, and your hearts. Always strive to listen for the meaning and the feelings that underlie those words. What are they really saying to you? Not what they say. You know, one of the things that we get into in long-term care is that people who have never used cursive language curse. They use language that may be insulting or offensive to us. Well, remember that frontal lobe, that they lose those inhibitions, and sometimes words come out that they never would have used before because they don't have the inhibitions. But what are they really trying to say to you? Figure it out and then validate their feelings. Man, it looks like you're really angry. I don't blame you. You know, can we talk about what's making you angry? Again, valued activities, anticipate their needs, rephrase communication to solicit feelings and opinions. Always, please, please, please focus on their strengths, not what they can't do, not their deficits. Change right now, right this minute. Don't see them for what they can't do. anymore. Only see them for what they still can do. Use their long-term memory. It's their strongest kind of memory. Avoid overload. If you are in an environment that's still using PA systems or they're still using audible call lights, go to an area where those are not if you're trying to have a conversation. TVs, as I said, the maximum attention span they can have is 15 to 20 minutes. So if they're sitting in an activity room in front of a TV, in front of an hour-long show, it's of no value to them. Reduce the distractions. Remove mirrors, confusing signs, things like that, especially for people, and we have lots of elders with dementia that are very sensitive to noise. Make sure that you can actually have a relationship with them in a quiet location. One of the most important things that we see are nighttime and evening activities, as long as because we have, there is a facility out on the East Coast that is only a nighttime facility. It's a daycare, only it's night care, and they have activities going on all night long because that biorhythm in their brain gets mixed up, and so they're awake at night, but they still need the rest in the daytime. Then consistency is so very important. And I've just listed a few things here that you can try. The one I want to focus on is, and I've talked about many of these things, the one I want to focus on for just a minute, and I think Barb's going to talk a little more about it here shortly, is music. The music center of the brain is separate from the cognitive center of the brain, and that center is never affected by dementia unless there would be a stroke in that particular area of the brain, which is very, very rare. We have opportunities to really focus in on effective music therapy, and we are hoping that you all will be advocates for the use of appropriate music therapy. Now, I will just tell you, music is a very individualized, sensitive area. If you would put me in a room with hard rock music that was loud, my agitation level would go way up. But if you would play something that had meaning for me, and I'm not just talking about a genre of music, although that's important, but if you would play songs that had meaning to me, you will reach me at an emotional level that you cannot reach me in any other way. We've talked about aromatherapy. We've talked about touch. Rocking chair therapy. When you rock for 15 minutes, melatonin, which is a hormone that is put out through in our body, a relaxing sort of sleep-enhancing hormone, melatonin will stay in your body for 6 hours if you rock for 15 minutes. One of the best things that an advocate can do is go in, sit down next to a person in a rocking chair, hold their hand, do a little hand massage, and let them rock for 15 minutes, and it will bring real pleasure to them. And the other thing I want to talk a little bit about is pet therapy. Pets are very, very valuable. In fact, it's one of my non-negotiables. I love my dogs, and I won't go to a place that won't let me have them. And the reason for that is that my dogs need me. And when they will die without me, and when I go back to that purpose sort of thing, where when we don't have a purpose anymore, we are nothing. Give them something that needs them. Okay. I so much appreciate having you on this webinar today, although it's interesting doing a presentation and all I see is the PowerPoint and Barb. I wish I could see your faces. I wish I could see the passion in your eyes and in your hearts, because I know you have them. I know that it's there. I'm counting on you. Thank you so much for your time. Did we get questions?
I don't see any questions yet, but certainly we've got time. So if anyone has any questions for Linda, please feel free to either raise your hand or type them in the question box. For now, I'm going to change our PowerPoints. I'm going to close this one and open mine back up and talk a little bit, as Linda talked about music and about specifically something called music and memory. And to start that off, I want to talk about a movie, a documentary called Alive Inside that came out, a year and a half ago, Linda,
Yes.
would you say?
Yes.
And I know that a number of you have seen that, so I'm going to try something that I've not tried before, so hopefully technology works. And I want to ask you folks a question about that. I want to find out how many of you have seen the movie Alive Inside, which came out a couple of years ago. So, yeah, we're getting some folks. We've got, I'll give you a couple more seconds for folks, either yes or no. We've got a lot of yeses, 62%. We got 57% of the vote open. We'll leave this open just another couple of seconds and see how we're doing. So we've got quite a few people that have indeed seen it. We're about 50-50 though right now, with 70% of the folks in. And so since 50-50, I think we're going to win. We're going to see just a little clip. I want to show you a clip out of the movie. It's a story of Henry. So I'm going to bring this over, and hopefully you'll be able to watch this on our screen. Whoops, lost it. Sorry.
When I first met him, he was very isolated.
Sorry, folks.
To a nursing home. They start to feel very
Technical
disconnected
troubles.
from their lives.
It won't move over. Well, there we go. We'll get it back. So the answer there is I will not make it bigger.
When I first met him, he was very isolated. Someone comes into a nursing home, they start to feel very disconnected from their lives, from who they've always been.
If you can imagine somebody who hasn't recognized their loved one in 5 or 6 years.
You know, I've been strong for 4 years. I just can't take it anymore.
So it seems tonight.
Music can do things which language can't.
When I learned that maybe more than 90% of a resident's time is spent idle, let's try this and see what difference the iPods would make.
I have one resident that barely opened her eyes. She didn't respond. Nothing worked. It was amazing once we put the iPod on her. She started shaking her feet, getting all I'm seeing her all over again.
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay?
Yes or no questions.
What does music do to you?
Give me the feeling of love, romance. Figure right now the world need to come into music, singing. You got beautiful music in. Beautiful, oh, lovely. And I feel the band of love, dream. And music therapy with Alzheimer's patients, something very powerful and primal is at work.
This iPod keeps me happy. It keeps me from crying. And when I'm upset, all I have to do is take out my music and it soothes my nerves and I go fast asleep.
And with an average cost of about $80, this is less than most people's daily medication costs. In terms of what difference it makes for the quality of life for an individual who's able to receive this, is just immeasurable. So for me, I can't think of any greater value.
Don't forget me when you grow. Remember me, but honestly I don't remember who you are.
Okay, so that's just a little clip, a little trailer from the documentary. And those of you who have seen the movie probably recognize Henry, who believes that's what the world needs now is music. And I don't know how we could even think anything but in today's world how important that music is to folks. So the music and memory approach, and you may have been able to have determined from that, is uses iPods to provide individualized musics with playlists specifically geared for that resident, as Linda talked about it needing to be what means something to her, not just even the genre of music, but the actual songs, the things that speak to her. The music and memory folks, the folks that put this together, have kind of identified that that's the music typically from what they would call, our coming of age music, that music that we listened to when we were 15, 16, 17, 19, 20 years old, that music as we were becoming adults. So for me, it's that 70s rock and roll. So when I'm cleaning the house, that's what's playing loudly in the background is Pete Seeger, right? So that's what keeps me going when I'm doing something I don't want to do. So I suspect that's probably the music that will mean something to me when I'm a person with dementia or with Alzheimer's disease. So that's really what it's about, and it's about, again, making it individualized for our residents at the time that they need it. I'm trying to bring that back up, but I'm afraid I'll lose my space. So what the music and memory people have found is, and others have found over the years, is that there are a lot of therapeutic benefits to personalized music. The participants are happier, they're more social, that it can help deepen the relationships between the staff and family members and the clients. That can help provide a calmer, more supportive environment. It can help resolve some of the behavior issues and problems that we see in our facilities that Linda talked about as being a way of communicating concerns. And one of those being, this feeling of not belonging and not being a part of things and having lost so much because of the dementia, and being able to bring a part of that back to their lives through the use of music can help alleviate some of those behaviors, because we're addressing those issues through that process. And certainly it's also been shown to reduce the need and the reliance on the antipsychotic medications, which is something that, as Linda mentioned, we certainly have an issue with across the country and as well in our state. So folks, the facilities that are participating and working with the music and memory program, there's a way for them to become a certified facilities, and they do that through a process of 3 30-minute webinars that are taught by the music and memory folks, and teach them really how to implement a program, how to start it, how to make it work. And then help to support them. And so in the state of Kansas, there are a number of facilities that are already certified for music and memory through this process. And I've shown, you see now on the screen, a list of those facilities. These are the current number, and I've lost count, somewhere in the neighborhood of 20 or so facilities that are on this list that are already certified. But one of the things that I'm seeing, and that I think Linda can also attest to, is that some of these folks have gone through the process of getting certified. They've bought the equipment, they've got the iPods, but they haven't really implemented. And so I know I think there's a couple that have, but we're also seeing folks who haven't. I was at one of these facilities, who shall remain nameless, maybe 3 weeks ago, visiting a resident in their dementia wing who told me she was sitting with 4 or 5 folks around the TV. That she pointed to that on the wall and said, "I don't like that thing." And I said, "Oh, what are you talking about?" And she says, "The TV. I don't like TV." And so I asked her, "What do you like?" "Like music." And we had a several-minute conversation about music, about what it meant to her when she was young. She used to play a couple of instruments. She told me she liked jazz. She did not like that rock and roll stuff her son played, because he also liked music and played a guitar. She did not like that. It was too loud. And we had quite the conversation about that. And when I went to talk to the administrator, indeed, they were a music and memory facility and certified for that, but they had not done anything with it. And so I politely suggested that she might be a really good person to start with. So I know that that's an issue. And I think one of the things then that Linda and I have talked about is there a way for us to help folks become music and memory certified, more of them, and then also to help them to actually implement the process and make it work in their facilities after they become certified. So some kind of exciting things. What I'd like to say is what can we as ombudsmen do? What can you do about this music and memory program? And I think one of those is really to learn more. If you've not had an opportunity to see a live inside, watch it. I know that a couple of the regionals, 2 or 3, have a copy of the on DVD. We've got a copy here in the state office, so I think right now it's out. One of the volunteers here in Topeka has it out. So I have it. Several of them have it. If you can't find it, if you can't get it any other way, call me and we'll find somebody who has it. It's also available on Netflix and is available for purchase from Amazon. So there's lots of ways to see it. There's also a number of other clips available on YouTube, different than the one I showed you, but showing different scenes from it. Check out their website, giving you their website there, the musicandmemory.org. There's lots of information on there. But there's also an opportunity for us to attend the certification training. So this webinar training that they offer to certified facilities there, I'm happy to offer that to us without any charge if we're interested in participating. And so in the future, I'm going to send out some emails to all of you to give you the opportunity to join in on their webinar if you would like to. They've asked kind of us to coordinate that rather than have you all contact Music and Memory yourselves directly, but to coordinate that through our office. And so if you're interested in learning how Music and Memory works and how it should be working in the facilities, and so that you can maybe talk more intelligently with the staff there about it, you can do that by participating in this certification training. You can talk to your facility about Music and Memory. If they're one of the facilities I showed you on the list that's already certified, ask them about it. Ask them how it's going. Ask them what they've learned, whether or not they need any assistance getting it implemented. Just talk to them about it. If they're not one of the facilities, you could talk to them about it again. You could, maybe they've heard about it, maybe they haven't. I don't know how you haven't heard about it, but there are facilities that I've talked to that hadn't. So talk to them about it. Ask them if they've ever considered looking more into the Music and Memory program to learn more about it. And the last thing what I'd say is kind of a cross my fingers and hope. We've put in a grant to KDADS for some grant money that they have available to help assist in promoting Music and Memory in more facilities. So what we've asked for is enough money to certify 30 homes. Music and Memory folks charge $1,000 for that certification. We've got a little contract. We've got the ability to contract with them for less than that if we can get this grant. So we'd be able to offer it for less money, but the grant would then provide the funds for that. And it would also provide funds to buy the facility 7 iPods and an iTunes gift card so they can have a way to purchase music and some other supplies that they would need. So get them a kind of a starter kit to get them started. And then also the plan is for us in conjunction with the partnership that Linda talked about, being her leadership in working on providing some opportunities for ongoing training and webinars for those facilities to talk about the program and their challenges and implementation, and to give them some other information about Music and Memory and other interventions and ideas for improving life for their folks with dementia care over the next year. So we're hoping that this grant comes through, and crossing our fingers on that. We should know something, I think, sometime in December. And if that's true, all the more reason to have more and more of our folks certified or participate in this certification training for music and memory. So let me know when I send the email out if you're interested in participating in that. And that's all I got. I still do not see any questions. I want to give us a couple of more minutes to see if anyone has questions, either by raising their hand or typing in questions. So far, all I've got is comments, says thank you, and thank you for attending our webinar is what I would say back to that person. But if anybody's got questions, please don't hesitate to type those in or raise your hand and we can unmute you. I see a hand raised. Let me unmute Corey. Corey? Can you hear us? Corey, do you have a question?
Can you hear me?
Yes, I can.
Oh, no, I hit the wrong button.
Oh, okay.
Sorry.
That's all right. It happens.
I think this was wonderful. I love it. I love doing this.
Well, good. I'm glad you have
these webinars.
I'm glad you were able to participate. I'm thrilled that Linda was able to be here with us as well. So thank you for being here.
Oh, my pleasure.
Okay. Any other questions or comments? We'll keep those open. I do have a one little kind of a housekeeping thing to mention. We do plan to continue to have these webinars on a monthly basis. We've chosen the third Tuesday of the month at 1 o'clock. I know that doesn't work for everybody, but right now that's kind of the time we've chosen. It works pretty well for a number of people, though, so hopefully that will work for you in the future. We will, however, not be hosting a webinar in December. We've got a lot of stuff going on here in the state office and opted to skip December, but so then we will be moving forward in January the 19th at 1 p.m. It'll be our next webinar, so stay tuned for information about what that topic will be. And I'm seeing no more questions come in yet. Appreciate everybody being there. It's never too late to ask a question, though. So when we've closed the webinar, if you've still got a question or a question you didn't think to ask, please don't hesitate to email me in the future anytime. I do have a question. Question is, can I use this PowerPoint to show my contact point? I'm not sure what the question's asking. Again, I assume you're asking permission to use the webinar as an education tool for your contact person at the facility. And Linda says, sure, no problem with that. If that's not what you were asking, that's good. Yep, at your facility. Yes, you may feel free to use the webinar in your facility. Linda does a lot of training in facilities, and this is a lot of the information she shares with them, but she can't be everywhere. So sure, she's grateful to have you share this information with your facility. Perfect.
Please use the contact information that this is Linda, that I put on the PowerPoint. If you have questions or special challenges, or I'm available by either email or phone. And one of the things that gives me that sense of purpose is when people call me and ask me questions. So you'd be doing me a favor.
We will. We are making a recording of this webinar as we have the last couple, and it will be available on our website on the login side, along with a copy of the PowerPoint presentation that Linda has and some other information on this topic that you'll be able to access. I'll let the regionals know when that's out there and available for you all. Our last PowerPoint and recording from last month's webinar is available. So if you missed that or if you wanted to review it, you can certainly go out and find it now as well. So I'm going to close the webinar and thank you again for coming today and for participating. And I look forward to seeing you all out and about. Talk to you then. Bye.
Okay. No,